Good evening, everybody. Thank you, Professor Ariel, for this kind introduction and also for the invitation to present for the first time in this conference. So, as you said, my presentation is entitled Neuropathy Affects Quality of Life and Depression in People with Diabetes. First of all, I would like to say that I have nothing to disclose. So we've been hearing a lot this evening about diabetic peripheral neuropathy, and I'm not going to go into much detail, but we know that this is a complication of diabetes. We know that it affects about 50% of our patients, and it predisposes our patients to severe functional limitations. We also know that it is one of the major risk factors for foot ulcerations and amputations. It is a very serious complication. It is primarily caused by high blood glucose levels damaging the nerves in the body and mostly the feet and the legs. It affects nearly half of all the people with diabetes. Hence, like we have been hearing this evening, we need to be very careful. We need to screen for this condition because we know that nearly half of all people with diabetes are likely to have this condition. We know that it has the ability to reduce the sense. So if very severe people may be unaware that there are injuries in their feet, it may lead to pain and poor balance. Unless it is carefully monitored, it can only get worse. The resulting loss in feeling may make it difficult to notice that there are injuries. And once there is even a minor skin injury, this unfortunately can develop to ulcerations and eventually lead to amputations. Diabetes also affects the circulation. So small injuries that obviously happen because one can't actually feel the feet because of neuropathy will and then, as I said, become even more complicated. Thus, we need to carefully assess and monitor for diabetic peripheral neuropathy. And we do know that key to controlling diabetic peripheral neuropathy is important that we need to manage diabetes very well, we need to take care of our feet, and we need to, as much as possible, refer to specialists such as podiatrists and neurologists when necessary, when we see that there are complications. Again, we've heard a lot of professors this evening talking about the importance of depression, maybe something with up to this stage, maybe as healthcare professionals, we have maybe neglected in our patients. We know that depression and diabetes surely rank amongst the most epidemiological conditions of this century. The most common mental health disorder is low mood, which eventually leads to depression. Low mood and depression is defined as having signs of sadness, feeling of anxiety or panic, worry, low self-esteem, tiredness, anger, frustration, thoughts about death, losing or gaining weight, and any alteration in sleeping patterns for more than 2 weeks. Depressed individuals who show at least 4 of these symptoms are known to be suffering from some form of depression. And we know that depression is also classified as a very common and serious medical condition. The relationship between diabetes and depression. So we know that if there is diabetes, depression can increase. And on the other hand, if there is depression, we know that factors relating to diabetes can only be more poor because someone with depression will obviously have poor control over his health behavior, will maybe not take part in physical activity, that these people tend to smoke more, these people will maybe consume more food, which obviously will lead to obesity. And we've heard this evening also about the link between neuropathy and obesity, and hence lead to poor glycemic control. The association between depression and chronic conditions have been confirmed in many studies and also have been confirmed to lead, obviously, then to a low quality of life. Although many studies indicated the association between poor control of diabetes and depression, appropriate attention as given to other chronic health conditions is still lacking with regards to depression in the specific population. So I'm going to introduce a few studies which we have conducted at the University of Malta in relation to this subject. And the first study that we conducted, the aim of the study was to determine the relationship between having peripheral neuropathy and the development of depressive symptoms amongst people with diabetes. We conducted a comparative non-experimental study, and University of Malta Research Ethics Committee approved our study. So basically, we recruited 95 individuals living with type 2 diabetes, age 65 and more, and the sample was divided into two groups. So we had 50 participants who had diabetes only, and then we had 45 participants who also had the complication of peripheral neuropathy. So our inclusion criteria was both male and female, patients living with diabetes for more than 10 years, and the participants needed obviously to consent to take part in the study. Participants were excluded if they presented with type 1 diabetes, had other comorbidities that are chronic in nature, such as peripheral vascular disease or arthritis, had a history of foot ulceration, or were taking any antidepressant medications. Participants who agreed to participate were interviewed once during our study, and we collected demographic data, including gender, age, level of education, medications, and the patient's latest HbA1c level. So in order to assess for depressive symptoms, we used the PHQ-9 questionnaire. The results of the PHQ-9 interview may be used in order to make a depression diagnosis according to the criteria of the Diagnostic and Statistical Manual of Mental Disorders. And we know that the early detection of low mood symptoms is important to prevent depression, as I explained earlier, since the literature suggests that any low mood symptoms lasting for more than 2 weeks is a definite sign of depression. So with regards to our statistical analysis, we use the Shapiro-Wilk test in order to determine the normality of our data. And the non-parametric Mann-Whitney test was used to compare the mean PHQ scores between our two groups, since our data was not normally distributed. The null hypothesis specified that there was no association between the two categorical variables and was accepted if the p-value exceeded the 0.05 level of significance. We also used the chi-square test to investigate the association between the PH9Q score classification being non, mild, minimum, moderate, or moderately severe depression. And obviously our two groups, which I remind you were people both with diabetes versus those people who had diabetes, but also the complication of neuropathy. So these are our results. So we had 52 males and 43 females in our sample. The number of participants with type 2 only and participants with type 2 and neuropathy were 50 and 45 respectively. The mean age of our population was 77 years. Most of our patients had reported to have secondary level of education, whilst only a few reported to have tertiary level of education. The mean HbA1c for group 1 was that of 5.9%, whilst the mean HbA1c for those people within group 2, those who had neuropathy, was 8.2%. And the mean duration of neuropathy in our group 2 participants was that basically of around 6 years. So according to our results, participants with diabetic neuropathy showed higher scores on the PHQ-9 questionnaire when compared to the people, to our participants who did not have peripheral neuropathy. The mean PHQ score for the diabetic neuropathy group was that of 6.09, which was significantly higher when compared to those people without neuropathy who only scored 2.24, obviously with showing a significant difference between the two groups. The chi-square test was used to investigate the association between the PH9 score classification and the groups. And participants in group 1 were more likely to have minimal to no signs of depression when compared to those of group 2 who were found to have moderate to severe depressive symptoms, again, with a statistical difference between the two groups. And maybe if you look at this graph, you can have a clear picture with the difference between both groups and the level of depression which was found in our study. So based on our data, the study demonstrates that depression and anxiety disorder exists more often in those patients with peripheral neuropathy when compared to those people who live with diabetes but have no complications. The message from our study and also in our paper, because as you will see later, this paper is published, we aim to alert clinicians to the fact that low mood and depression are common in patients with diabetes presenting with neuropathy, and that this condition could only complicate matters and impair positive outcomes if both are overlooked and not addressed simultaneously in the clinical scenario. Most of the time as clinicians, and I think everybody can think this about himself, we do know that we tend to look and ask, do investigations with regards to physiological matters. However, we tend to forget to ask questions with regards to psychological aspects. And now we know for sure that there is a relationship between two, and obviously as clinicians we must not forget to look at also the psychological aspects in our patients. If low mood and depression are detected early, obviously a prompt treatment plan should be implemented, including, again, both pharmacological and non-pharmacological options, depending on the severity of our patients. And most importantly, we're referring to the appropriate healthcare professionals, obviously, who are more experts with regards to dealing with low mood and depressive symptoms. So discomfort caused by peripheral neuropathy and the emotional problems associated with peripheral neuropathy expressed by our patients should be addressed in the management of diabetic neuropathy in order to prevent especially aggravation of depression in our patients, and most importantly, to improve their quality of life. As we heard before, screening is indeed very important. But screening not only, again, for neuropathy is important, but since we know now that there is this link, we also need to screen for depression. And again, maybe as we heard earlier, that we need to also look and revise the present screening guidelines, who definitely do not address this factor. Like all studies, we do know that this study did have limitations. Obviously, the first limitation is our small sample size. Another limitation could have been our diagnosis with regards to peripheral neuropathy. We made use of the Tangram monofilament and the tuning fork. However, again, as we heard earlier on, these are the standard tools which are used in primary care in order to diagnose diabetic neuropathy according to the present and current screening guidelines. We also know that maybe a limitation could have been with regards to the questionnaire. Obviously, this was self-reporting, so we asked questions and patients reported what they were feeling. We also do know that sometimes there could be instances when maybe patients do not express themselves in the correct manner as they should. So we do acknowledge that these could have been the limitations of our study. The take-home message is that mental health must not be relegated to the bottom of priorities in our national health systems. So not only us as healthcare professionals should we remember to test for psychological conditions, but also national health systems and health policies should be looking into this condition and obviously including them as part of their priority lists. So the association between diabetic neuropathy and depression is confirmed, with significant depressive symptoms found in patients with neuropathy when compared to patients with diabetes with no complications. Quality of life is thus affected in these patients. Complaints caused by diabetic peripheral neuropathy and emotional problems should be addressed in the management of diabetic peripheral neuropathy in order to prevent depressive symptoms. Hence, a call for change in screening practices to help identify those patients with diabetes and with depressive symptoms is warranted. As I said, for those of you who may be interested, the study has been published in the Review of Diabetic Studies, and the full study can be found in this paper. Also, we have published another paper. This is very recent. This has just come out this week, which also this has been published in the International Journal of Lower Extremity Wounds, again, which advocates that we know that people with peripheral neuropathy, as we said, this leads to complications and amputations. We know that this is amputations are feared more than death sometimes, and it is time, as I said, to look maybe at guidelines in order to try to address this situation. Thank you very much for your attention.